Hi, and welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us. Hi, welcome back. We're so excited today to be joined by Dr. Daniel Butler. He is a board-certified dermatologist, assistant dean of student affairs at the University of Arizona College of Medicine, and the director of Inflammatory and Aging Skin Research Program. And he does amazing research around geriatric medicine, aging skin, and basically what happens to us as we get older. This is, I think, a really cool combination of things we've talked about in the last episodes. We've talked a lot about inflammatory skin disease and how it leads to the diseases we see in dermatology. And then we've had a few episodes on how we need to get rid of the term anti-aging and longevity and basically what happens from a science standpoint as we age. So I'm so happy to have Dr. Butler here because he is just the perfect combination of all of that. He does all of the things with inflammatory skin disease and then just studies the aging skin really, really well. So thank you so much for joining us.
I'm so happy to be here. I'm a big fan. I've been a big fan of yours since you were Dr. Ku's fellow, I think 2 years in front of me or 3 years in front of me. So anyway, I've been following your career and I'm just so happy to get to chat with you here. Thanks for having me on.
Yeah, it's so great to have you. And I'd love to hear, I mean, you were doing so much, so we could probably start anywhere in that journey, but I would love to hear about kind of the latest and greatest and the research you're doing currently around the aging skin and what that looks like. And of course, we all care about how to increase our longevity of our skin and health, but I would love to hear some updates.
Yeah, well, I appreciate this, and this is something that I hope can spark interests in others as well, because there's really not one thing to look at from the aging skin and inflammatory disease conundrum. What we're really working on is understanding how aging independently becomes a risk factor or a moderator of some of the diseases that we see. So for example, atopic dermatitis is a great disease that we have a ton of knowledge about and certainly have more treatments for in the last 5 to 10 years. But how does age change how we see that as it manifests in the 50s, 60s, 70s, 80s? And what does that tell us about aging as a process systemically and in the skin? So we've been doing research projects that look at different types of immunologic phenotypes in atopic dermatitis over different age ranges. We've also looked at how age can be a modifiable risk factor in access to medications. So one of the things that we've seen is that it's actually harder to get medications, certain medications, when you're on the Medicare formulary versus not being insured whatsoever. So there's a lot of pieces to this aging story from a basic science standpoint, from a healthcare delivery standpoint, and it's really a fun opportunity to be able to look at aging and how it reflects in our practices, how it reflects in our morphology, and how it reflects in the clicks that we have in our EHRs and the insurance companies that we get our prior authorizations from. So there's a lot to do there. I don't consider myself a specialist in anything. I just sort of bang my pots and pans together and say, hey, this is something to think about. And I get to then engage basic scientists looking at aging, epidemiologists looking at aging, and expert clinicians who are looking at a lot of diseases that have aging patients. And we see that across dermatology because, fun fact, 40% of all dermatology patients seen in the United States are over the age of 65. So it's a huge population and it's only growing. We all know that as dermatologists, but certainly something that's very real for us all.
It's so true. I mean, when I even think about my practice, and I practice in Palo Alto, where I think there is a little bit of an older population here as well. So sometimes it feels like it's like 90% of your practice, the same things you see of which are the downstream effects of basically sort of that collagen collapse, fibroblast collapse, and we see our patients with like the thinning skin, the forearms falling apart, and then all the way to the inflammatory things like a lot of itching, right? Like why are a lot of our older patients just itchy? Is that just all part of the dysfunction, the damage that's happening to the fibroblasts and the nerves over time? And it's really, really interesting. It's these we all see, whether you kind of call yourself, necessarily like a geriatric dermatologist or not. It's just a lot of the phenomena that we're seeing. I do feel it's changed a little bit over, like, even since my training, where you would maybe see the forearm on a patient and say, oh yeah, that's just normal aging, it's atrophy, and then explain why that's happening and move on to the rest of your skin exam. Whereas now I feel like there's kind of, not that we have great solutions, but more targets are coming out of, well, okay, let's address that itching, or let's address the thinning of your forearms that's causing you to have 5 Band-Aids on at any kind of given time. So I'd love to kind of hear your thoughts of how you've seen that field change. How are we taking care of the aging skin, and this is probably a loaded question as well, but like how much more do we know about the mechanisms leading to the aging skin, leading to all these phenotypes that we see?
Yeah, it's a great question, and I'm sure I'll spend a whole career trying to figure it out. There's a lot of untold stories here. I will tell you that, we have a lot of people doing brilliant research, both in the basic science realm, looking at the specifics that you're looking at, fibroblasts, certainly immunology, barriers, those types of things. There are very few people looking at those with specifics to aging. A lot of them are looking at, how do we modify the aging process, but not how do we understand, A to B from a non-aging to aging standpoint. So there's certainly a lot there. And I totally agree with you. Even in the last 10 years from a clinical side, we've grown a lot in our understanding of these aging phenotypes. I give credit to our specialty, give credit to some of the development of medications, but certainly some of these targeted agents have given us a step back with regard to what are the causes of some of these things that we saw. So when I was in residency, an older patient would come in and they were itching, and we just sort of shrugged our shoulders at it. We called it pruritus, which I think is sort of the most silly thing that we could do in a specialty. Someone comes in with itching, and then we give them the diagnosis of itching. And we are finally getting a little bit more sophisticated thanks to some of these new medications. And that's really no criticism to our specialty. I think a lot, particularly with older adults, the frustration was we didn't really have things to treat you with. And thus it was frustrating for us as providers to then see you because we couldn't help you. And that's where there's this inherent conflict comes up. And you've seen that in a lot of diseases. For HS was like that for a really long time, where we really couldn't treat it with many things. And now we have agents for it. And so it becomes an easier challenge to be able to see those patients. But certainly with older adults, it's been a wild ride. And clinically, one of the challenges with older adults is they don't present the same as younger cohorts with similar diseases. So a great example, I used atopic dermatitis. With atopic dermatitis in older adults, oftentimes you won't see the same morphologic changes. Oftentimes, I would argue that you're really not seeing any morphologic changes. You're just seeing predominantly itch. And unfortunately, when you take the visual away from a dermatologist, it's really disarming. And so I think now we're starting to be able to wade into that gray area, but that's all new for us. We don't have vernacular nomenclature for those types of patients. And you see that across the board. Another great disease for this is pyoderma gangrenosum. So pyoderma gangrenosum was sort of classically taught of, a younger woman or man with inflammatory bowel disease has a expanding ulcer after multiple antibiotics. And that was kind of how it was taught. But if you look at the epidemiology studies, the most common presentation of PG in the nation is multifocal ulcers on the legs of older adults.
Oh, wow.
And so it's almost like we sort of changed this paradigm of how we think of these diseases. So this is my long-winded way of saying, the next piece clinically is to sort of understand that there's this older adult endotype or sub-presentation within our flagship diseases that can give us clues from an immunologic standpoint, from a nerve standpoint, from a fibroblast standpoint of what's going on, but they still reflect and respond to some of the same things that we use in other patients. So it's a huge, major challenge that I'm really excited about, and I think it's grown tremendously, with really itch being the kind of leader, or at least the template of how we're going to start to endotype these patients.
That's fascinating, because you're right. If you see an ulcer on the lower extremity of an elderly patient, just right away you're going to think it's vascular, or you need a vascular surgery consult, and might leave it at that. Most of us probably should want to go out of our way to never biopsy that, but that would probably be the only way to cinch the diagnosis and figure out that it's PG and kind of go from there. But it's so true. And then my mind obviously kind of goes through, we've had a couple of conversations about like AI and the imagery. And so the diversity needed to catch things, and how not subgroups don't present the same way. And I've heard of kind of diversity conversations as far as subgroups, but I don't know necessarily that it's well known to kind of include the aging population as almost like, a separate just clinical path correlation. So that's actually really interesting to kind of think about. Like, things will just look different as you age. It's not going to look the same. And you're right with itch too. It's like, it's one of those things that's dramatically changed for us.
Yeah, I mean, I think there's a lot to tease apart about taking a step back and looking at how we define diseases. A lot of it is visual, and then when you understand that maybe the visual isn't the same in subpopulations, it forces us to take that step back. Which, from a progress in medicine standpoint, we've done it for literally thousands of years, but it's not super comfortable to do, because you want to say, well, the definition of the diagnostic criteria for disease X is this, and that's when we can open the door and allow them to have that treatment. But really, these subpopulations challenge that, and certainly aging or older adults, have that nuance to
That's
them.
true. The atopic dermatitis criteria, it's very much towards the pediatric population, right? I feel like back in the day in our training, it was almost like, if it's not a pediatric patient, if they're older, just immediately start looking for all this other stuff, other systemic stuff going on, right? And that, I feel like that's, and I think we still do. We just want to make sure there's nothing underlying going on leading to the itch. But I felt like that's kind of, we just left it at that years ago. It was like, do the systemic workup, and then, well, that's it. And then I think the patients were like, well, what's the next step? And I think it took a long time before getting to, and I think to your point, we don't like not having options for treatment. I think that makes physicians very uncomfortable. Which I think I've seen a lot of our patients, even in the last decades or so, go towards a lot of alternative medicine, which is great too. There's a place for that. But I find that was a world where they were like, well, let's try other things. Whereas for us, we need very clinical data. We need large studies showing things are effective and have the science before we start making recommendations. So
yeah, I mean, I think it's oddly enough, the lack of an answer is our answer to, or one of the pieces of the answer to burnout, because it gives us this sort of future challenge of how do we change the schematics. It gives us control over some of the challenges we face in clinic. Like one great example of this in older adults is, that older man comes in with 6 basal cells and, just had some major, procedure and has been in and out of the hospital. What do you do? And, I get asked this question all the time. And the answer is, there is no answer. This is something you have to wade into. What's the right treatment in this patient is having a really frank conversation about the risks of each of these lesions. The one on the eyebrow may be a different risk than the one on the back. The ear one would be different than the one on the arm. And there's gray area to this. And I think that makes us all uncomfortable, but it's really a fun way of being in control, connecting with patients, and really having a vision of communication as the true reason of being a doctor, as opposed to getting the answer right, which we're sort of trained to do with our testing, and how we're basically how we've gotten through the medical system, the medical education system thus far. I think it's really fun to do, and the older adult population is front and center in that gray area.
Yeah, that's such a good point that actually, like, there's different factors to physician burnout. Like, we all talk about the EMRs and all these different things, but you're right. I think what we hate the most is like not knowing how to, not being able to figure something out and then not knowing how to help someone. And that's probably like the highest level of burnout. So hopefully as we have more and more things coming out, treatments coming out, it just makes it, like, if you see a condition, it actually makes it manageable and like maybe a fun thing rather than like, oh my gosh, no, not another one of this coming up. Actually, speaking of things that make physicians uncomfortable, not to fully change the topic much, but you had a really great post once on LinkedIn and asking the question of, should academic physicians be on social media? So this is definitely a little bit of a change from the topic we were just talking about, but also kind of related because a lot of our patients are looking for information on these things on social media, and many times we're not there because that's not our comfort zone. So I'd love to kind of hear your thoughts about it. There's definitely been this gap of all this cool stuff we know is happening on the academic level, and then the stuff you find on social media, which is not that. It's not representative of that. So there's been this huge sort of gap that sort of needs filling. So would love to hear your thoughts.
Oh boy, I have so many thoughts on this, and I think this is a really fun debate, and not to again get off topic, but I think debate in academics or in all walks of life, but specifically in conversations like this, it's needed. It's okay that there's two sides of the equation. It's not that one's right and one's wrong. But my thoughts on this is that any physician should have a presence on social media. It shouldn't be forced. You don't have to have an inauthentic voice. But I think we're at we're in an era where information is being passed on social media, and the more academics or educated physicians stick their head in the sand and are only reliant on the historic ways of communicating information to each other, I think we lose the ability to really touch so many different people. And so I do think there's a responsibility for all physicians, specifically academics too, to have a social media presence. Again, not to promote, themselves exclusively, but just to be part of the conversation, because a lot of the stuff on social media now is sort of skewing to one direction, and we just sort of passively allow that if we're not part of that conversation. And there's a reality that this is where the eyes are, this is where the ears are. And I say this is social media, that's where it is. And so sometimes in order to really get the information that we want out there, we have to wade into that water. And again, I'm not promoting that everyone needs to have their own brand or anything like that, but even just opening a Twitter account or an Instagram account or a LinkedIn account to build a community there and follow the people who you trust, I think that's really, really important. And so I firmly believe it is, but it needs to be done authentically. It needs to be done in a way that, is true to you. So, not forcing anything.
Yeah, no, I agree.
I'm
And
curious.
I think in dermatology too, we are just probably the providers and physicians who are very much facing this, right? Because there's the whole skincare world as well, and then there's this overlap with medical dermatology. And then I think a lot of people don't necessarily really know what we do on a daily basis. I think, most people associate dermatology with, Botox and fillers, and we do those things too, but we sometimes do these other things like entire inflammatory disease spectrum and skin cancers and everything else. And I don't know if that's necessarily kind of a known thing that what a dermatologist even does on a daily basis. And on the second hand of it is there's just skin. It's funny. It's like the largest organ, but it's like the most businessified organ, right? Like there's not as much of a business around the liver. Maybe there is that I don't know of, but like how much of just commerce and just business is around just the skin, and like how much stuff is out there that people are trying to sell, and this will do this and this will do that. And so like, you're at the top of the game with geriatric medicine, aging skin. And we're saying, there's so much to be learned, but then yet people are going on social media and saying, no, we figured it out, whichever company or whatever they're selling, we know, and this is the thing you need. Which I always find it so interesting. I think there's that discrepancy is that, there is so much still to be learned, but yet, when you see what's out there, I mean, it's a lot more marketing than science, which probably is, to your point, why we need to be there as scientists and physicians.
Yeah, I mean, there's so much to this, and it's individualized. I just really think that the future of communicating knowledge is different than it was 15 years ago, and we all have to acknowledge that. And specifically in dermatology, we've sort of thought that like academics is a silo and private practice is a silo, and skincare is a silo, and like we need to start thinking of this as how cool is this specialty? Like there is so much engagement and interest in skin and skin health and skin longevity and how that relates to everything. The more we start to think of it as like, well, there's one way to do this, and this is the only way that you can do this is, submitting a manuscript to this place. It minimizes the people that we could touch, the information that you can communicate. And I see this as a really fun thing for the future of dermatology, going to the podcast, is, we are lucky that there's a business of skin. I think, this is my personal opinion, is like we're lucky that there's a lot to this. It can be weird to navigate. It can be challenging. It can be mucky. But that's what we went to med school for. That's what we, spent all those hours studying. Right. Is you navigate that, you talk about it, you communicate it. There's going to be conflicts of interest. You talk about those. You lift up the hood. I'm certainly someone who thinks that it all should be out there, and we should use it all to the advantage of helping people answer questions and connecting with people. And that's what we're here for. That's what we ultimately did this for. So I think it's really fun, and that's what I think social media can in a good way bring out. Obviously there's a lot of bad things about social media
right
too.
Right, but maybe the more you have credible sources and credible voices, it drowns out some of the other stuff, because I think people, like our patients, innately they want to get higher level evidence quality when they're getting their information, but there's just kind of a scarcity out there, so it's kind of hard to know what to kind of listen to. And it's an interesting point you bring up too with academics. Traditionally there's been this whole conflict of interest, like everything was like, well, no, don't do this, don't do that. There's been a lot of like no's, whereas I do find that that's changing a lot too. Like we've had a couple of episodes about with different centers, like Mayo Clinic was on. We talked about the incubators they're starting within academic centers to basically get these thoughts out there and be open to it. And of course, you have to still do the conflict of interest reporting and make sure everything. And physicians are, I think, the most very ethical group of people. So there's no, and we follow directions really well, and we're rule followers. So there's no problems with those kinds of things that are added in there. But assuming you go through all the right channels, so many cool things that dermatologists are getting involved with as well. So, and then to kind of bring it back to the clinic, I'm curious how you find this. So I have a very kind of elderly population here that I see too. So I do medical and I do cosmetics. So very often, a lot of my elderly patients, in addition to all the things we discussed, the itching, skin cancers, all the above, a lot of times they are asking me about the cosmetic procedures as well. Do you find that in your clinic too? Do you find it might be a different population, but seeing the geriatric, clinic, do you see that, and how do you kind of encounter that?
Absolutely. I mean, the anti-aging, and this is of course not exclusive to, and the desire for sort of that cosmetic side of things, even though I don't love that word. It's sort of like an arbitrary word that like the insurance companies have put on us at like what will or won't be covered. So anyway, that's I digress. But the older adults, you really get they get put in a bucket very quickly. If they have an age or they have an appearance that looks a certain way, then they shouldn't be asking about certain things like cosmetic procedures. And I encourage everyone to try to avoid that thinking. And this goes back very easily to the discussion of Mohs surgery or how to treat a basal cell or a squamous cell, which is like never make an assumption. I have 55-year-olds who don't want Mohs and they're fully functional and they know the risks of doing an EDNC versus a Mohs, and that's a great decision for them as long as they know the risks and they'll follow up. And same thing with a 90-year-old who, wants the best cure rate for a basal cell. And while I think maybe an ED&C would be a great option, they want Mohs, so that's their choice. It's the same thing with purpura on the arms of an older woman. If that bothers them, that's something that we all need to validate and understand that shrugging our shoulders and saying, oh, that's normal for someone your age is really dismissive. Just as if, an 18-year-old came in with acne and we said, oh, that's normal for someone your age.
That's true.
So there's nuance to this, and I think it's a lot of it's baked in, that sort of distinction of cosmetics and not, and what's covered and what's not covered. But unquestionably, older adults are still interested in that stuff. And I always highlight the skincare industry, which is something as dermatologists we really don't learn a lot about. It's a $60+ billion industry. Like, there is a lot of eyes, a lot of ears, a lot of hands putting lotions on that we really are not exposed to in dermatology training. And we can't be blind to that, that's something that people want. And I do think that, specifically as we look at a growing older adult population, we have to be really validating of those concerns and not just sort of parroting what an insurance company has told us is or isn't cosmetic. And so, yes, back to your question, I'll get off my diatribe, which is like, no question, older adults are very interested in the cosmetic procedures. And we have this wonderful ability to provide it, whether it's through a laser or through a topical like a retinoid or through, advanced skincare regimens. I mean, there's cool things that we can do.
Yeah, it's actually an interesting point you bring up too with just the arbitrary what insurance will cover and won't. And I think that's, going back to what doctors are comfortable with. We're not comfortable with patients racking up high bills, so we might not even mention options. Like, we kind of think, well, yeah, we can maybe do this and that. That's probably what the insurance will cover, but then might not go into the other things. And then aging has been added to the ICD. So I don't know what your thoughts are if things are going to be covered at a higher rate eventually, but I do have my elderly patients where we are prescribing the Retin-A for their face, the tretinoin, we are doing lasers, and their skin ends up looking great over time. But I'm like, well, why couldn't we do this for your forearms at a lower fluency, so we're not burning their arms or anything, but why couldn't we add more collagen in these areas where you have serious functional impairments, right? If your skin is breaking open that frequently, or even the lower legs, probably a little riskier area to do laser. But if they're having so much trouble where they're getting just that crazy thinning and the fibroblasts are so senescent that they're getting constant squamous cells and keratoid xanthomas, why couldn't we do things but usually we could, of course, but usually we probably don't because of all the limitations of cash pay, and those are probably conversations we don't necessarily want to have with patients. So I'm curious to see how that ends up changing, if any of these biostimulatory therapies get some level of coverage at some point.
I love the ideas that you bring up, and they're endless. Dermatologists, again, the business of it is really cool because ultimately there's going to be ways to engage this back to what we sort of traditionally think of as pathology. And, whether that's, preventative strategies for SECs for, the legs of an older woman, or, using retinols for purpura on the forearms in older adults is actually one of the best treatments for purpura, for that, stubborn sun-related purpura that was historically called senile purpura, which I don't love that term. But retinols have been actually pretty effective for that, and we do use a good amount of it. And you can sort of get it at all levels. You can get your OTC retinol, you could get Differin over the counter, which is one that I often use as long as it's not too irritating to the older adult on their forearms, and even tretinoin if they want to go that route. So I think there's a lot of potential for it, and just thinking about us as people who have sort of the medical side and abilities there to treat, with this sort of traditional prescription system. And then also this sort of interventional side that I don't think all doctors have with lasers and these sort of cosmetic potions that have been concocted. It really makes us in a great way dangerous because we have a lot of different skill sets. And I that makes me excited for the future of the specialty, but it's really the current establishment. And we just have to figure out new ways of utilizing all of our skills.
That's fantastic. And actually, since you mentioned the future, that's a good segue. At the very end of our podcast, we always ask, since it's the Future of Dermatology podcast, what things do you see happening in the future, or what are you most excited about?
Oh boy. I think first and foremost, this is sort of unrelated to older adults, but maybe peripherally, the dermatology has changed dramatically in the last 15 years with the ability to get targeted agents. Psoriasis, I really can't even imagine treating now in a way that it was 25 years ago. We just have so many agents. I'm so excited when a psoriasis patient comes in because I almost know we're going to get them better and clear them.
Yeah.
And that was not something that they could do 10, 15, 20 years ago, certainly not as easily. And we're seeing this in a lot of different diseases who are now getting their heyday. And that makes me so excited for patients. The fact that now AD has a lot of targeted agents, and we're going to see this same era in prurigo nodularis, and we're seeing it in hidradenitis suppurativa. I know I'm missing others, but there's things around the corner for itch. There's things around the corner for pyoderma gangrenosum. There's so many different areas that are being targeted, and what we historically thought of as these orphan dermatologic diseases that now we're going to actually have the ability to treat with something other than these, massive immunosuppressive agents. And I love that for all of our patients. And then to me, as I put my educator hat on, this always comes back to the future dermatologists, the people who are just starting to get into med school now, or even some of our residents, to equip them with more skills is just so exciting. And to get to give them the opportunity to treat these people and clear these people, or at least mitigate some of their discomfort is such a gift. And I'm so excited to bring that next generation of dermatologists in. So I know that's a cheesy answer, but ultimately it really is the next generation, and giving them the ability with our studies and with our teaching and all those things, giving them the ability to change lives. I love that. So those would be my two cursory answers, but there's 25 other things I could talk about.
Yeah, absolutely. No, and I totally agree with you. I mean, when we were at UCSF, we were doing Geckerman still, right? Which is still going on over there. Although I hear they're closing it down, which is sad as well. But then we have all these other new targeted therapies. And I totally agree with you with the residents and medical students. They keep us young too, even though we're still very young. I mean, Yeah. But as we get up there in the numbers, it's so great to have them. And it just reminds you of why we do what we do as well. They kind of help keep that excitement going. But thank you so much for joining. You do such amazing work. I'm just so glad that you were able to take time out of your extremely busy day to join us, and we learned so much.
Thank you so much for having me. I'm so excited by this, and thanks for putting this out there for the entire dermatology community. I know everybody appreciates it. A lot of people have been talking about the podcast, so I'm excited to be on, and thank you for doing it.
Let's go. Thank you. Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.